Okay. Thank you, everybody, for being here this Valentine's Day. Happy Valentine's Day to you all, and especially to all of you who are caregivers. My name is Nicole Christensen. I am a board certified patient advocate and the president and founder of Care Answered. Care Answered's mission is to access the best care for our clients while giving their loved ones peace of mind, as well as empowering all patients. I am also the author of From Crisis to Calm, and I'm very excited to have you all here and with our special guest, Rochelle Pachman, who I have known for a little while, almost a year now, and she does incredible, incredible work, especially with caregivers of those who have dementia and for the patients themselves, those who are struggling with a dementia diagnosis. So a little bit about Rochelle before she takes it away is that she has over 35 years of experience working with dementia caregivers. She is a licensed clinical social worker and she's a dementia caregiving coach. And she has a very unique take on this specialty, and she comes from having a unique experience and with a lot of devotion, and she's a wonderful person, and happy to have her as part of the Care Answered family. And I'm really looking forward to having you hear everything she has to say, as well as listening more myself, because I learn every time I hear her speak. So take it away, Rochelle.
Okay. Thank you so much, Nicole, for those kind words and introduction. And thank you for having me as a guest on your webinar. I truly am honored to be associated with you and your practice. In case anyone doesn't know, Nicole is truly, I think, a force of nature, not only in terms of the work that she does with people and their family, but also she is an incredible resource and leader in the community of professionals that serve older adults, for which I think all of us are thankful. So thank you, Nicole, for having me, and a happy Valentine's Day to everybody. I love the idea of doing this on Valentine's Day. And it's also a special day in terms of it being Ash Wednesday, and it's quite a nice pairing in terms of it also being the start of Lent. So I'm going to speak about some of what I consider to be essential concepts related to understanding dementia for caregivers. Nicole has asked me to touch on a few certain particular topics, which I will do. I'm going to speak for a while, and certainly following that, if anybody has any questions, Nicole and I strongly encourage you to feel free to let us know, and we can, I'm happy to answer any questions you may have, and even some discussion if you like. Okay, so dementia is a word that is sometimes misunderstood. Dementia means when a person has cognitive deficits. Those deficits can include difficulty with memory, insight, judgment, reasoning, organizing and planning, abstract thinking, following directions, completing multi-step procedures or complex tasks, difficulty with word finding, decision making, difficulty with orientation to day and time, and perhaps not recognizing familiar faces or objects and what they're for. So dementia is a lot more. It's about a lot more than just memory deficits. Memory deficits are of course, the most obvious ones, the most obvious deficit, but all of those other deficits are really, really important to understand. What a dementia what someone with dementia needs is for us to meet them where they're at. And in order for us to be able to do that, we have to really understand those deficits and understand that when they're presenting with difficult behavior, challenging behavior, confusing behavior, agitation, anything along those lines, the reason for the behavior is contained in that list. So caregivers would really be wise to embrace and connect to that list, because the reason for any kind of challenging behavior essentially is in the list. And it's really important to do that for two reasons. One is, like I said before, it helps us to meet the person where they're at, and that's exactly what they need from us. But it also does something very, very important, which helps the caregiver to not take personally the presentation of the person with dementia. And that happens all too often. And it's understandable because, of course, we're humans, and it's natural for an automatic personal emotional response and interpretation to prevail, when what instead we should be doing is to be making a dementia interpretation, a clinical interpretation in the moment, on the spot, from what we're getting from them. And the way we do that directly is to drop down that list of deficits. And if you drop down that list of deficits, that's how you make the dementia interpretation. So what you want to do is you want to think of it as sort of like you're driving in the correct lane. If you're doing that. If you don't do that, you're going to be veering off into the lane of personal interpretation, and you don't want to be in that lane. For sure, you don't need me to tell you that it can be overwhelming and complex to interpret the presentation of somebody with dementia. You don't need the extra stress to have on top of that by being overwhelmed with, with emotional and personal interpretation. That's an extra stress that a caregiver can really, manage much better by making the clinical interpretation. So, so that is a really, really essential concept. Another really essential concept that I'd like to talk with you about is about what is treatment for dementia. Treatment for dementia is really about the environment. And that's what I do, because while doctors play an important role in terms of diagnosis and ongoing evaluation and consideration and prescribing of medicine, that's the extent of their role. And that role is really, really small compared to the role that the caregiver plays, which is the role of managing the environment. So understand that the environment is the essence of the treatment for dementia. A successful environment for all people with dementia, regardless of where they are physically, is an environment that promotes three things. Those three things are safety, structure, and stimulation. Safety, of course, is the most important thing. Without safety, nothing else matters. Safety means that the person with dementia is safe from their deficits. So that means that their access to anything potentially harmful or toxic is either blocked or supervised. So that means all the things, or most of the things that we keep in the kitchen, the stove, the microwave, the toaster, knives, the things that we keep under the kitchen sink, like cleaning solutions, the things that we keep in the bathroom, under the bathroom sink, and in the medicine cabinet, prescription medicines, over-the-counter medicines. It would be not uncommon at all for somebody with dementia to perceive that they had a headache at 12 o'clock, take Tylenol, and at 12:15, still perceive they had a headache, forgot they took the Tylenol 15 minutes ago, and take some more Tylenol, and that could go on and on and on and on, with obviously, a very bad outcome. So access to anything potentially harmful or toxic must be blocked or supervised. That also goes for cars, knives. I said knives, cars, knives, guns, alcohol, cigarettes, matches. This is the only time that Rochelle Pachman will ever be heard to make an analogy to a child when speaking about older adults. But this is the time that I'll do that. And so another way to think about it is if you don't give it to a child, you don't give it to somebody with dementia. Now, somebody with dementia can feel like they're using the microwave or making their own cup of tea or something like that, as long as the buck stops with someone else in terms of making sure that indeed the appliance was shut off. They can take their own medicine by, swallowing the medicine with a glass of water, as long as someone else is managing the medicine and making sure that they're taking not more and not less than what they have to take. After safety comes structure. Structure is very, very important, and this goes to the deficit of organizing and planning. Structure means that there's rhythm, pattern, routine, familiarity. The more, the better. Because people with dementia have a hard time with organizing and planning, that manifests, for example, in, okay, it's 11 o'clock in the morning. What would be a suitable activity for me to do right now? If you can't organize and plan, which is something we take for granted, if you can't organize and plan, then the person doesn't really know what they can do at 11 o'clock in the morning, but they can be plugged in to an activity if there's a flow and if there's something planned for them. So I don't mean rigid boot camp, but I do mean a flow to the day that's similar to how yesterday was and how tomorrow is going to be. A getting up time, a lunch time, a dinner time, maybe a morning activity, an afternoon activity, a rhythm and a flow that's predictable and familiar is optimal. Now, that's not to say that you never ever deviate from the routine. Of course, you have to deviate from the routine. Going to the doctor is essential, but it's outside the routine. So, of course, we deviate from the routine when we have to. Just realize that it's normal for them to become a little bit overwhelmed with something unfamiliar and out of their routine, but it doesn't mean that we don't do it. As much as possible, a reliable structure, a familiar flow is optimal for people with dementia. And the next is stimulation. Stimulation is just that, the opportunity to have some kind of social and mental stimulation in the day, in the week, is really important. In the home setting, this can be challenging because often family members aren't really sure how to do that. So the guidance for activities in the home setting is that you want to think about something that is familiar, but simple and straightforward. So what that means is that this is not the time for new gadgets or new hobbies. If it is not familiar to the person, this is not the time for word games or crossword puzzles or jumble books, or anything anything that they would have to learn. Instead, what you want to do is think about what's familiar to them and adapt it to a level that they can engage with it. So, for example, a generic example of that would be cards. There are a lot of people with dementia who were very good bridge players or canasta players. But those games can be really complex. They are complex and they can become, too complex for people with dementia. But someone who has played bridge or cards, bridge or canasta, let's say, for a long time, will still have card sense and will still enjoy and connect to the familiarity of cards. So we take the game of bridge or canasta, and instead we adapt playing cards to an easier game. For some people, that means gin or war or a game like that. For some people, we need to adapt it down even further, which is where we may even just make up a game where we deal the cards and make up a game where we make a pile of the hearts and the spades and the clubs, or we have to adapt that down even further and make a game out of separating the red cards from the black cards. So what I just showed you was taking a familiar activity that might be too complex and figuring out at which level do we need to adapt it down so that the person can engage with something familiar, but at a level that they can, feel connected to it. Another example of that is a lot of ladies may have been crocheters or knitters, and they have, and perhaps they made, all kinds of sweaters and things back in the day. Crocheting a sweater is complicated, but that can be adapted down where someone starts the yarn on the needles, and the person can just kind of do that rote, stitching. They may end up with a 9-mile scarf, but that's okay because it's not about the product, it's about the process and just the familiarity of the stitching of the rote stitching can be very, very, very good for them. Adapting down further, I had a lady recently whose mother was a knitter, and she couldn't even do what I just said. She couldn't even do the stitching. So what I told her, suggested to her daughter, and she does it all the time now, is she got skeins of yarn, and she told her mother that she needs balls, that she needs balls for a project, and her mother just sits and takes the skein of yarn and makes a ball out of it. And her daughter thanks her for this great help. I don't know what she does with the balls. It doesn't matter because remember, it's about the process, not the product. But her mother feels very connected and stimulated by making, by handling the yarn. So safety, structure, and stimulation should always be part of and the environment of somebody with dementia. Now, everybody's different, people have different interests, they have different ways and settings in which they live, different family availability. So everyone needs their version of safety, structure, and stimulation. A word about assisted living. When people choose that option to have their loved ones cared for in assisted living, realize that safety, structure, and stimulation is inherent in an assisted living setting, of course. So there are benefits to being at home. There are benefits to being in assisted living. Nothing is ever, completely perfect, of course. But regardless of where the person is, safety, structure, and stimulation should always be emphasized and prioritized. I'd like to talk about optimal approaches and responses. This is also a real area of challenge for caregivers and, something that I think is really essential to understand. If you recall the deficits that I reviewed initially, one of the deficits that I emphasized was that, well, a few actually, aside from memory at the beginning, some of the most challenging deficits are insight, judgment, and reasoning. Insight, of course, I know you know the definitions of these words, but in this context, insight is self-awareness. Somebody with dementia lacks insight, so they lack self-awareness. I have people say to me all the time, my mother doesn't want to acknowledge there's anything wrong with her. She won't admit that she forgets. She won't admit, she won't acknowledge that she has these problems. So it's not that the person is willfully seeking to deny or denying that they have problems as much as they truly don't have awareness of them. So when a person with dementia says, I'm fine, I can do this by myself, I don't need a companion, I don't need any help, they are being sincere. They truly mean that. It's because they don't have insight. Judgment is the ability to size up a situation and recognize what would be a good course of action. So somebody with dementia lacks judgment, and so therefore lacks the ability to realize what, given this set of circumstances that I might find myself in, or that my daughter is talking about here, what course of action would therefore make sense? A person with dementia can't do that. Reasoning is the ability to follow along someone else's line of logic, process it, use it and retain it so that you can make sense of what a person is trying to convince you of. Person with dementia can't do that. Insight, judgment, and reasoning are not available to them. So in terms of reasoning, though it's our instinct to reason, it's our instinct when someone is having a hard time about something, when we're trying to comfort them, when we're trying to get them to see that we're just trying to help them and just trying to, get them to understand our view of things. We don't realize it, but we launch into a big, long, lengthy explanation with many, many words in the hopes that they will be able to connect to what we're saying. But somebody with dementia can't do that because that's reasoning. Speaking reasoning to somebody with dementia is like speaking French. If they don't speak French, we would never dream of speaking French to someone and expect them to be able to follow us. So reasoning is just like that. And the more we reason, the worse the interaction is going to be, because all of that reasoning, all of that talking becomes overwhelming to the person with dementia. It sounds after a short while like a bunch of gobbledygook to them. They just can't process it. And so what happens is they're just going to say no, and they may get loud and they may get assertive and they may get verbally aggressive in response to this attempt to reason. And so I can't emphasize enough how reasoning really needs to be avoided. Now, if the person is having a good day, a good part of a day, and you can get across what you want to get across in about 3 sentences or less, fantastic. That's fine, all good. But if you see that you're going above 3 sentences and they're not getting it, they're not going to get it. And you must realize that that's therefore too much reasoning, and you really have to stop. So instead of reasoning, what would be a better approach? If someone is having a hard time with something and the caregiver wants to, try to comfort them, the best thing to do is to acknowledge what they have said. They need to feel heard. So you want to acknowledge what they have said, then offer some reassuring words, and then try and distract to something else. And those 3 things should be almost in 1, maybe 2 sentences at the most. Again, you don't want to have a whole big encounter of a lot of talking, because that's just going to overwhelm them. So instead of talking so much, realize that the value in the interaction like this is not in words. The emphasis is more on mood and tone. Mood and tone is something they don't have trouble with, like they have trouble with words. They have trouble with words. They have trouble with reasoning. They don't have trouble with as much trouble with mood and tone. So if your mood and your tone is calm and soft and calming and reassuring, and your facial expression is kind and smiling, and your body language matches that, it may not be magical, but you're gonna have the best chance of conveying calm to the person. And so they're going to be much better able to settle down about whatever is, causing them to be overwhelmed by your mood and your tone more than your words. And then what goes along with that is the absolute need for caregivers to understand, even though this is really hard. And that is for caregivers to understand that we must manipulate information. Manipulating information is really a polite way of saying lying. And I want to be really clear. Lying is part of the treatment for dementia. Some people call it therapeutic fibbing, call it whatever you want. But when I speak with caregivers, I really like to be very, very clear. And I want caregivers not to have any ambivalence or any doubt about what I feel about what is the right approach. So lying absolutely is part of the treatment for dementia. The truth for the truth's sake is not the greater good. The greater good is that we get the help get the person from point A to point B in any way that achieves that, with them being as content as possible about it. So, for example, if the caregiver knows that we really have to introduce it's time to introduce a companion, of course, 100%, we expect the person with dementia to resist that. Why? Because their insight about why they need a companion and their judgment about why this would be a good idea is just not available to them. So we know they're gonna resist it. A question that they might often have is, well, do you have to pay for this? I don't even need this, but do I have to pay for something I don't even think I need? In that situation, the caregiver would be wise to say, no, you don't have to pay for it. Either something like Medicare pays for it, which it doesn't. Medicare pays for it, or Dr. Smith's office actually sends people like this because they're concerned about people like you and they just want to help you. Isn't that fantastic? Or anything that the caregiver knows that will particularly resonate and be understandable to the person with dementia. This is extremely important because to bombard somebody with dementia with the truth for the truth's sake is only going to overwhelm them and take you away from meeting your goal, which is to get them from point A to point B. That's what you always want to realize, is what the caregiver has to realize is that's what they need to do. And manipulating information is an important, tool to that end. Now, part of what caregivers need to do in general is to manage, maneuver, and manipulate words, objects, and context. So I just explained about manipulating words, but we also need to do that sometimes when it comes to objects. For example, very commonly, a person with dementia who may be diabetic might forget they're diabetic or forget that they had their, allotment of 2 cookies that day. And they can open up the pantry and they can see the Oreos and say, "Oh, I love Oreos, and I want to have some Oreos." And the caregiver says, "Nope, you can't have those cookies because you already had your cookies." "No, I didn't." "Yes, you did." "No, I didn't." "Yes, you did." Obviously, this is not useful. So what we want to do always is to get ahead, get in front of that. And instead of having the package of cookies in front of them, the caregiver would be wise to maneuver this object by taking the cookies out of the box that says cookies and putting it into an empty box of, let's say, rice. So the caregiver knows that that's where the cookies are. The person with dementia opens the pantry and doesn't see any cookies. No cookies, no problem. The mail is another great example. Very often people with dementia get in trouble with the mail because they're focused on the mail, they'll take the mail in, and they'll either lose important mail, misplace important mail like a bill or a check or something like that, or they can become triggered by a bill that they get upset about, or a bank statement they might get upset about. So maneuvering, manipulating, managing the object of mail often becomes very, very necessary. A lot of sweepstakes, by the way, sweepstakes is a big one. Very often they'll get mail, they'll open up the envelope that says you're going to win $1 million, and they'll say, "Oh, that's great, I'm going to write a check for $1 million." And of course, we know they're not going to win the $1 million. So this kind of mail really doesn't need to be, get into their hands. And again, having a discussion trying to reason with someone with dementia to explain to them that nobody wins these sweepstakes, you're not going to win $1 million, is reasoning. So instead of that, get in front of the problem by not letting the mail with this about the sweepstakes get in front of them to begin with. And that's what I mean. Those are two examples. There are many. Those are just two examples of what I mean when I say that it is the caregiver's role to manage, maneuver, and manipulate words, objects, and context. So that's sort of the the essence of what I wanted to present and what Nicole had asked me to present. I realized as I was talking is that I meant to just tell you just a little bit about me, and I was so looking forward to giving you all this information. I forgot to just give you a word about my background, so I'll just do that now, and then very happy to take questions if anybody has any. So just a word about my background so you understand where all this comes from. So I've had a lifelong passion and interest in working with older adults, literally since I'm 16 years old. I've worked in a variety of settings, but it really was the setting of geriatric psychiatry where the bulk of my career has been. I had the incredible good fortune of being trained when I got my master's degree in social work at the Hillside Zucker geriatric psychiatry service many years ago. I was trained there alongside geriatric psychiatry residents and psychology interns and externs. And I really got a very special, unique training. I then worked there in the geropsychiatry clinic. And then after that, for about 25 years, I was the clinical partner of Dr. Alan Steinberg, who was or is a very prominent geriatric psychiatrist. Our practice was in Centereach, and our model was a unique model. After Dr. Steinberg would diagnose someone with dementia, and as he was treating them, he would insist or highly recommend, strongly encourage family members to sit with me so that I could teach them about all of these non-medicine aspects of what is treatment for dementia. And I did that for about 25 years. A couple of years ago, he retired. And when he retired, that's when I launched this private practice called Dementia Solutions, which is my opportunity to provide this guidance and education to caregivers, regardless of who's treating them now. I also provide guidance, education to professional caregivers, caregiver agencies, assisted living settings, et cetera, as well.
Thank you so much, Rochelle. That was so helpful. I have notes here. One of the questions I would ask if you could just repeat the first list that you gave us, because I know I want to write it down and maybe others do too.
Sure. So I'll say it slowly so it gives people a chance to make sure that you're writing it down. So these are the deficits that are consistent with dementia. They are the most obvious one, which is memory, insight, judgment, reasoning, organizing and planning, abstract thinking, following directions, completing multi-step procedures or complex tasks, difficulty with decision-making, calculating, word finding, and confusion about person, place, and time, recognizing familiar objects and what they're for, and familiar faces.
Perfect. Perfect. And I just really, it made me think even more about how as a caregiver, you think about those things and not make it personally about you or about your past relationship, right? Because we always have a history, if it's a family member, certainly, of your relationship, and you can think it has something to do with that. But if we focus on those deficits, it can really, really help. So thank you.
That's a really good point, Nicole. And what I would say about that too is that a lot of people ask me about personality, and a lot of people will say to me, "No, no, no, this is not dementia. This is the personality. Her personality. She was always rigid. It always had to be her way. This is personality. This is not dementia." And the way that people need to understand about that is that personality, yes, is still there, but when a person has dementia, dementia goes to the top of the list in terms of what their presentation is about. So they can have had a challenging personality. They can have had other kinds of perhaps mental health issues of some sort, or habits or whatever. I'm not saying those things disappear, but I am saying that they then become secondary to the role of the dementia, which also is connected to the need to, which is connected to the how and the why of making the clinical interpretation in the moment on the spot.
Absolutely. I also loved what you said about mood and tone. I
Mhm.
think that's for all people.
Yes.
Right? When we
Yep.
think about it, it's not often what you say, it's how you're saying it. Which brings me to the quote of it, I may not remember your name, right?
Yeah.
Or who you are, but I'll remember how you made me feel.
Yeah, exactly.
Um,
Hmm.
and that's true for all of us, and just most important probably all the time, and especially on this Valentine's Day, to be showing love and calm, but especially for those that are that who have dementia. That is
Hmm.
definitely the case. I don't see any questions here in the chat. If you don't want to put in the chat, if you want to just take yourself off mute, you can feel free to do that as well. I know that was, you did a great job. You were very thorough in a very short period of time. Again, I have lots of notes. So does anybody else have any more questions? Well, if that is it, that is it. And I thank you again for being here. And I thank you, Rochelle, for such an informative piece here on our webinar. And oh, we have a question. Sorry. Who is the best doctor to see for a diagnosis of dementia? Or
So
what kind of doctor? I'm assuming they're
mhm.
saying.
Yeah. So the best kind of doctor to see is either a neurologist or a geriatric psychiatrist. Those are the two types of specialists that are able to diagnose dementia. Um, Somebody with dementia, if dementia is suspected, um, a person really needs to have a complete workup. A complete workup. So dementia is a diagnosis of exclusion. So if someone is older and exhibiting confusion and memory difficulty, we first have to rule out any potential treatable or reversible causes. Just because someone is 80 and confused doesn't mean they automatically leave the office with a diagnosis of Alzheimer's disease, and shouldn't. Although that happens way too often, actually. So there are things that need to be ruled out, like a vitamin B12 deficiency or delirium, an untreated depression, syphilis. God forbid, a brain tumor. All these things really need to be ruled out. So a complete workup should be done by one of those two specialists, and it would involve the exam by the clinician of the person. It would involve imaging of the brain to look for abnormalities in the brain, and blood work. And sometimes, to be complete, extended neuropsychological testing is sometimes ordered, which is a battery of really focused hours-long questioning and examination to kind of really fine-tune the diagnosis. That's not essential. It can be done without that, but often it becomes part of the workup.
Great. And to that question also, and Michelle, you can correct or clarify anything from your experience, but there are different kinds of dementia. But I feel that, Michelle, from what you said, all of anybody who has a diagnosis of dementia, this is true for. Doesn't matter the kind of source of one's dementia. So everything that Rochelle has spoken about, if it's Lewy body, if it's Alzheimer's, if it's dementia with Parkinson's, as far as the communicating and caregiving, it's the same. You can use these same tools that you spoke about. Is
Yeah,
that
that's
correct?
exactly right. I would be a zillionaire if I had a dime for every time I've been asked, what's the difference between Alzheimer's and dementia?
Right.
So what people need to understand is that all people who have Alzheimer's have dementia, but not all people who have dementia have Alzheimer's. So when I speak to caregivers, I use the word dementia because Nicole, you said it perfectly. The environmental management of the person is the same essentially, regardless of the cause. Now, it is important to know the etiology, to know the cause. Yes, absolutely. But in terms of a caregiver's understanding of concepts related to how do I approach the person, how do I understand the deficits, really, it's not different, based on the cause. The concepts that I put forth today, as well as many, many, many other essential concepts that are important to know, are really applicable to people with dementia, regardless of why they have dementia.
Perfect. Well, thank you again, everyone. Thank you, Rochelle. I'm excited that you were all here today, and happy Valentine's Day. And let people know it'll be available for playback. This will be one of the last non-monetized, actually, webinars that we have. So take advantage of it. It'll be available, and I'll send it back as a playback too, just in case something caught your attention, maybe some chocolate or what have you. And you missed any of it. Okay, so enjoy and thank you all so much. Have a great day.
Take care. Thank you, Nicole.
Thank you. So